Another high yield topic in GIT is carcinoma of the esophagus. On the basis of histology, it has two types: squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma arises within the squamous cells that line the esophagus by simply their carcinomatous proliferation, whereas adenocarcinoma, as its name indicates, arises from glands, the mucus secreting glands that line the esophagus, and thus they show glandular differentiation. Carcinoma of esophagus, if it is squamous, is always in the upper and mid esophagus, where adeno is always in the lower third of esophagus. The risk factors are also different: achalasia, Plummer-Vinson, and celiac disease for squamous, whereas GERD, when differentiates into Barrett esophagus, that leads to adenocarcinoma, along with it fatty diet and obesity. Clinically, the person with carcinoma esophagus is of old age and shows weight loss like all other cancers. Apart from it, the obstruction to food passage causes dysphagia. Dysphagia here is initially for solid and later it develops for liquids. When the obstruction increases in size, it is slowly progressive and develops over 2 to 3 years in most cases. Apart from it, hoarseness of voice may occur when the tumor grows out of the confinements of esophagus and invades recurrent laryngeal nerve lying close to esophagus. Chest pain may also occur when the tumor pressurizes the adjacent structures and causes pain. Bleeding, which may be occult, can also lead to iron deficiency anemia. Diagnosis is done by endoscopy and biopsy, and that not only visualizes the tumor, but also we take a sample from it and then confirm the cancer by histopathology. To stage, we can use a CT chest, abdomen, and pelvis. You can write it down in staging of any type of cancer throughout the body. Endoscopic ultrasound can also be used. Ultrasound is of two types: transthoracic and endoscopic. In esophageal carcinoma, we use endoscopic ultrasound. The endoscope is projected down into the esophagus and its tip has ultrasonic probe. It directly emits ultrasonic waves onto the tumor and so helps in finding out the extent of wall penetration by the tumor. PET scan, which is expensive and is done in only certain cases, can be done as well for staging. FDG, a radioactive form of glucose, is given to the patient. It gets into the cells and so into cancerous cells as well, which take it a lot because they are highly metabolic. This glucose emits gamma rays and it is detected as hot spots. Bronchoscopy can also be used to stage the metastasis in trachea and bronchi. Laparoscopy to help find if there is any abdominal metastasis, but these two are not mostly done, they are done in rare cases. Treatment, like any other cancer, involves 4 steps: surgery, chemotherapy, radiotherapy, and palliative. Surgery is the treatment of choice in esophageal carcinoma. It is called esophagectomy. Name indicates that the tumor part of the esophagus is cut out and the remaining 2 ends are anastomosed. The tumor as well as the tumor-free margins are removed, and so it's curative. Chemoradiotherapy. Chemotherapy uses cisplatin and 5-fluorouracil, and palliative surgery involves 4 things: stunt, laser, ethanol injection, and radiotherapy. Stent is a metallic tube-like structure. It is passed into the esophagus in the area of tumor in collapsed form. It is then expanded accordingly. So the esophagus is intubated and food can pass through the stent, and it helps relieve dysphagia. Laser and ethanol injection directly into the tumor decreases its size and relieves dysphagia. Radiotherapy is used to relieve bony pain due to bony metastasis. Surgery is the treatment of choice, and chemoradiotherapy is used as adjuvant. Radiotherapy is not indicated in adenocarcinoma, which is radioresistant. Palliative is used only to relieve pain and dysphagia and does not cure the patient. Staging depends on the fact that the carcinoma of the esophagus grows outward from lumen towards the deeper layers of the esophagus and finally outside to the adjacent structures. So if mucosa and submucosa is involved, we call it T1. When it grows outward to muscularis propria, then T2. And if it involves the outer layer adventitia, then T3. If it grows further and involves adjacent structure outside the esophagus, then it's T4. Treatment is according to the staging. T1 and T2 involves esophagectomy with or without lymphadenectomy. In T3, we do esophagectomy with adjuvant chemoradiotherapy. And in T4, we only do palliative procedures since it's in. There are three approaches for esophagectomy: Ivor-Lewis, McKeon, and Transhital. In Ivor-Lewis, the anastomosis is done in the upper chest, when in the later two, it is done in the neck. Ivor-Lewis procedures, upper midline incision and lateral thoracotomy incision are done. Upper midline incision mobilizes the stomach, whereas the right thoracotomy mobilizes esophagus. After this, the tumor and tumor-free part of the esophagus is removed, and the stomach is then moved up into the upper thorax, anastomosed with the remaining tumor-free esophagus. Anastomosis is thus below the collarbone bones and in the upper chest and not in the neck. In this procedure and in the next, thorax is opened. In this approach, along with the upper midline and the lateral thoracotomy incision, an extracervical incision is performed. The stomach and esophagus are mobilized in the same way, but after the tumor and tumor-free margins of the esophagus are removed, the stomach is pulled up till the neck, and anastomosis is done in the cervical region. This procedure is thus applied when the lesions or the tumor is located within the upper part of the esophagus near the neck. Transhital means that incision is applied in the diaphragm and approaches through the diaphragm. The incision upper midline is used along with cervical incision. Lateral thoracotomy is not done, so thorax is not opened. The surgeon uses both his hands. One is passed up through the diaphragm, through the incision, and so esophagus and stomach are mobilized. The tumor and tumor-free part of the esophagus is resected, and the stomach is pulled up in the similar way to anastomose it with the remaining esophagus. The anastomosis here is also in the neck, cervical anastomosis.